Awesome. Cool. Thank you so much. All right. Good morning, everyone. On behalf of the Confidential Advocacy Program, I'd like to welcome you all to today's webinar series. My name is Jackson. My pronouns are they, them, and theirs, and I am one of the confidential advocates with the Confidential Advocacy Program at OHSU, otherwise known as CAP. And today I have the privilege of being joined by Jean Haan, MD, with their presentation on supporting transgender and gender diverse patients with trauma-informed care. Before we start, I'd like to acknowledge the land we live, work, and learn on in Portland, Oregon, and Multnomah County. We're the traditional lands of the Multnomah, Cathlamet, Clackamas, Tumwater, Tualatin, Kalapuya, Wasco, Malala, Cowlitz, and Watlala bands of the Chinook and other tribes who've made their homes along the Columbia River. And we acknowledge the history of genocide and forced removal from this territory and honor and respect the many diverse indigenous people still connected to this land. If you're not in Portland, I encourage you to look up the native land you reside on and acknowledge the history. I'm going and just wanted to get into our presenters for today. Don't have any disclosures, and nobody on our committee or planning committee does either. And before we get started, I also wanted to introduce how you all could reach out to us. Please don't hesitate to contact us at any time during the webinar. And know that we have 5 hotlines or support lines throughout all OHSU campus locations in the state of Oregon. And during normal business hours, these numbers are answered by our OHSU-based advocates, Stacy or myself in Portland. And then after hours on the weekends, these numbers are routed to our community-based agencies and partners who serve specifically in those locations. So in Portland, that's called a safety. In Monmouth, we have Sable Health. In LeGrand, we have Shelter from the Storm. And Ashland, there's Community Works. And in Klamath Falls, there's Marta's House as well. So yeah, I just want to make sure that you all know that we're here for you both during the webinar and after through our support lines and email addresses. And then so on our support line, 833-495-2277 or CAPS, as well as any of those other business support lines with those with your specific campus location. You can easily access either myself or Stacy during business hours. Also CAPS support at ohsu.edu. We can't guarantee the same level of confidentiality through email that we can through a phone call, but we can say that it'll be as confidential as we can make it in terms of receiving your email to CAP support. So feel free to reach out through either of those channels. And then I mentioned myself, Jackson, my pronouns are they, them, and theirs. And yeah, Stacy's pronouns, she, her, and hers. And then our program director, Stephanie McClure, is also available if you ever need to reach out to anyone in relation to maybe any other needs outside of advocacy or anything at all with our department. Today we have 2 ASL interpreters and we'll have captions available. We're very grateful to EdCom and Language Services for making this possible and ensuring this webinar is accessible. These webinars are recorded and hosted on our website, ohsu.edu/cap. A little bit just about CAP, real quick to kick us off. Our mission is to center the voices of those who have experienced sexual misconduct through education, advocacy, empowerment, connection, support. We do this through employing our values: social justice, intersectionality, inclusion and equity, self-determination, safety and health. We recognize that the importance of our work is to center the voices of those that are most vulnerable, so we can provide support for everyone. And this, Title IX is a landmark civil rights law that protects against sex-based discrimination, which has been defined as including sexual misconduct, which is what the confidential advocacy program at OHSU covers. And so we provide services to anyone who's experienced sexual misconduct. This is a quote, no person in the U.S. shall, on the basis of sex, be excluded from participation in, be denied benefits of, or subjected to discrimination under any educational program or activity receiving federal financial assistance, which applies at OHSU, and our program at CAP is centered around that. And then just to give you a quick overview of what sexual misconduct at OHSU can look like, it's, really an umbrella term used to denote sexual harassment, exploitation, assault, rape, domestic violence, dating violence, and stalking. All forms of sexual misconduct are prohibited at OHSU. And within the Title IX system, CAP can provide a variety of services to people to help them understand and navigate the system. That is the center of our advocacy that we do at OHSU. So that can look like emergency funding for things like changing locks at a residence, covering the cost of parking, transportation, housing relocation. We can also help with petitions, interim and supportive measures. Students who experience sexual misconduct have the right to request supportive measures, which are ways that the institution can fulfill its requirement to remedy acts of harm when it comes to sexual misconduct. And the following, and to remedy the effects of harm that sexual misconduct may have on the student's right to access and education that's free from discrimination and harassment. And so anyway, in any case, there are a lot of different ways that you can reach out to us and access advocacy inside and outside OHSU through our program. We also provided quite a few referrals, both internally and externally, and within the community. CAP provides 3 primary services: emotional support, crisis intervention, and access to services and resources. In terms of emotional support, we believe in validating experiences and let clients know they're not alone, and acknowledge what they've experienced and that it's not their fault, and respect their autonomy, as well as 100% their confidentiality when it comes to working with us as advocates. And then we provide crisis intervention services from medical response programming with students and a specific medical advocacy program that Stacy and myself have gone through so that we can advocate alongside SANE nurses when in-person services are available. And as well as helping folks with emergency housing. And then lastly, we help connect clients to various services and resources, whatever that may look like, but specifically around education, Title IX, criminal justice, and civil justice. And then some opportunities for healing that we provide regularly. We offer trauma-informed yoga that's accessible through our website. We also offer art therapy, which is accessible through a six-week program that you work with an advocate on. They are video-based, so it's on your own time. We just ask that over the 6 weeks that you're in touch with an advocate while you work through the art therapy programming. We're also currently working on our Survivor Voices project. We invite all OHSU members who are survivors of harassment, discrimination, and violence to join this project and collectively assist us in advocating for needs, resources, building community, and helping us identify ways to support survivors and our OHSU community. And if you have any ideas for things that are helpful for survivors, we would love to hear from you. Our email address and our phone numbers in the bottom corner. We're also looking for members for our advisory council, which will work in tandem with the Survivor Voices project. The purpose is to increase the transparency of the project as well as make sure that we're held accountable to and amplifying the voices of communities who experience the highest levels of violence. And we invite members of the Black, Indigenous, and people of color communities, as well as members of the LGBTQIA+ communities and people with disabilities at OHSU to join. And just to be clear, it's also neither of these are work groups. CAP staff and volunteers are 100% doing the work. This is a space to build community and identify actions to center the voices of those most impacted by violence at OHSU. And then also we would love to offer time for anyone who would like to volunteer with CAP, as well as become a confidential advocate themselves. Just reach out directly to us, again, through either of these lines. We also offer a mobile app for staff, employees, and students to use, both to support survivors as well as to access resources themselves and better understand what resources look like at OHSU before, during, or after working with our department. And then briefly, just to touch on how to best support a survivor while we have your attention. We'd love to cover this briefly. Knowing your reporting obligations. It's very important to disclose upfront with someone when they come to you about an experience that they've had. Making sure that before they disclose information about their experience that you might have to report, taking any opportunity to understand your reporting obligations and state them to somebody. So if you're in a management or a supervisory role, most likely you have reporting obligations. And then also moving right into affirming. I'm glad you told me, this is not your fault. Believing someone, I'm here to support you. Connect, you are not alone. How can I best support you? Direct, you have rights and options at OHSU. Would you like to speak with a confidential advocate at CAP? And empower, it took a lot of strength to speak about this. You have been doing a lot to keep yourself safe. These are all core concepts and best practices in supporting survivors and one another at OHSU when it comes to navigating complex situations. So moving right into our speaker for today and our topic. Jean DeHaan, MD, uses they, them pronouns and is a medical provider in the Portland community. I will let them speak more to their past experiences that brought them to where they are today. A couple topics we're going to touch on that are important as it relates to working with trans and gender diverse individuals in clinical settings, including how to work with survivors of trauma and those who are survivors of sexual misconduct, assault, or intimate partner violence. We will move a little bit past the Trans 101 standard definitions with LGBTQIA2S plus communities. We're more than happy to offer resources also. Please reach out to CAP, and we can also communicate with Jean if there are specific resources that you're looking for. And a few things that we will touch on is just identity-based services and providers. And, essentially identity-based providers is when an identity is shared between a provider and patient. This is something that's very common in advocacy services for survivors of sexual assault and intimate partner violence or domestic violence. When it comes to folks working through elements of their trauma, it enables for quick normalization of patient experiences as it relates to their identities, and helps quickly validate their experiences. And so this is also, culturally responsive services is another service that's common in advocacy organizations. And that's when organizations implement services with their patients' cultural experiences in mind. I guess in terms of trans health or working with trans and gender diverse providers, it is helpful when people have a shared identity with that patient population. And that definitely is the same when it works in working in my own role. I've definitely seen it not just patients, but students and employees who are trans or gender diverse reach out specifically, sometimes wanting to speak to someone with a that may have a better understanding of the common experiences that they're going through. And we work directly with Bradley Engel, a community-based agency that we refer folks to for culturally responsive services. They offer the Healing Roots program, which has Black and African American identifying advocates who serve Black and African American identifying individuals who are looking for services specifically relating to their culture, in addition to their advocacy that they need as survivors. Bradley Engel also has LGBTQ advocates who specifically work with individuals from the LGBTQ communities. That's where I worked prior to working at OHSU. And then briefly, just wanted to also introduce the 6 principles of trauma-informed care from the Substance Abuse and Mental Health Services Administration, or SAMHSA. The idea between these 6 principles: safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, cultural, historical, and gender issues. These are all elements that, in terms of trauma-informed care, are also work based on the setting that they're in. So in an identity-based healthcare setting, such as trans health, the best practice would be to also have providers of a similar identity to their patient population or to those available to speak to individuals when it comes to trauma-informed care. So SAMHSA specifically states that these 6 principles apply best when also looking at the organizational setting and structure, which identity-based healthcare structure would deem in terms of trans health, that we look for the similar patient population. And so, yeah, again, if you have questions during today's webinar, please email us, capsupport@ohsu.edu. We can follow up with you. And if you need additional support, please do call our hotline during or after the webinar at 833-495-2277. We aren't sharing any confidential or identifying information. So if you do have a question that needs an individual response, we'll respond to you directly. We would like to take everyone's questions and follow up with everybody as a group, provided we receive enough questions for that. And yeah, thank you so much in advance, Jean. I think I'm going to turn it over to you now to present on how to best support trans and gender diverse patients with a trauma-informed lens.
Thanks so much, Jackson. I really appreciate that introduction. And I see Kevin interpreting for us today. If I'm going too fast, please slow me down. I can do that sometimes. So I'm gonna go ahead and go to the next slide, Jackson. Okay, so I am a trans person. I grew up in the Pacific Northwest. I went to med school down at UCSF in San Francisco. I came back up and trained in OBGYN at OHSU, and then I've been working at Kaiser now for about 2 years. I'm white, I'm Jewish, I'm transmasculine. I'm I would say very identifiable as someone who's gender diverse in the hospital setting. I get a lot of kind of questions and kind of interface with people's understanding or misunderstanding of my gender identity every day in my clinical life. And I came into medicine for the specific purpose of working with trans people and providing gender affirming care. I think I came out initially when I was 17 as genderqueer, and just had negative after negative after negative experience with healthcare providers and being totally invalidated. And I started working at Q Center. Actually, I was the first person hired there and built a health and wellness program as part of their curriculum. And as part of that, we had started something called the Access to Compassionate Care Conference. And we had our first conference, actually, ironically, in the Kaiser Town Hall, which is now where I work. And I just remember seeing all these amazing providers, not seeing anybody reflected from my own identity. So I think I'm so happy, Jackson, that you bring that up. And that was in SAMHSA's, identified in SAMHSA's kind of outline there for what's important for providing care. Because if you don't see yourself reflected in your care team, you're automatically not going to trust them as much as you see someone who has your similar identity. So I was like, well, I was an English major. I wrote my thesis on queer as folk in the L word. I guess I can go to med school. I don't know. So then I went and got a second bachelor's and went to med school. And so here I am. You can go ahead and advance, Jackson. I have nothing to disclose other than a lot of my images are from Hyperbole and a Half, which is like my favorite graphic novel ever. I highly recommend you look at it. I can give you the resources, or sorry, the references if you need it. That's it. That's all I got. Go ahead and advance. So, okay, we have a big objective today. I don't think we're going to be able to do this in 40 minutes or whatever, but ideally we like to deconstruct the heteropatriarchy, white supremacy of medicine that we all know is all too real and kind of is a huge force leading to all the worst health outcomes that we all experience as marginalized people as we interface with the system. So how do we do that? I mean, I would say empowering people to become providers from marginalized communities is huge. That's a huge part of it. And then when I look at myself and the work that I need to do every day, so I'm a white transmasculine person, the things that I need to do to help deconstruct the medical complex that I'm working in is to make sure I don't become complacent in the patriarchal white supremacist ideals that surround me every day. Work daily to address my own racism, advocate for my own community as a trans person, as a queer person, and be open to feedback every day in a non-defensive, grateful capacity. So that being said, I am not an expert in anything that I'm talking about other than this is my job and this is what I do and this is who I am. But if there's anything that you see reflected here that you're like, oh, hey, you know, that's actually, I would say differently, or I take issue with that, or just let me know, because I'm here to learn just as we all are. You can go ahead and advance, Jackson. So we can kind of go over, I'm happy to skip over some stuff, move through stuff more slowly, and Jackson, feel free to interrupt me and say, hey, can you spend more time on this, or we can cruise through this, no problem. Briefly, we'll go over terminology so that everyone knows that we're on the same page with language, and then kind of talk about the homophobia, transphobia, all these different forces that are affecting how your patients are experiencing care. And then I'm a gynecologist, and so what I'll speak to is kind of specific to my practice. But I think if you look at the practices that are probably the most sensitive for a lot of us as trans people, or people who have experienced trauma of any form, a GYN visit is really up there in terms of having a bad day for a lot of people. So anyway, go ahead and advance. So this is super, super basic. I started giving talks, I don't know, 10 years ago, and it's amazing how now when I am able to interact with a live audience, back in the before times, people understand this now, right? So sex is not gender, it's not sexuality. It's nothing tells you one thing about another thing. The only way you can know anything about any of them is by listening to how the person in front of you identifies and characterizes these parts of their identity. Go ahead and advance, Jackson. Also, so I am a doctor. I trained in allopathic medicine. I you learn as a med student, you have it drilled into you. You know, the first sentence of your history of the present illness is, this is a 65-year-old man with a history of COPD and congestive heart failure who presents with worsening onset of dyspnea. Okay, so the beginning of every single identifier is they want to know sex. They want to know, and they want to characterize it into a binary, they being the medical complex. So I definitely had to learn that language and participate in that performance for the sake of my medical education. But we all know, I think everyone who's listening today probably, that sex is not binary and gender is not binary. And there's a huge spectrum of all of these different things. So now that I'm an attending physician and can do my own thing with some usually like cis straight white man attending telling me that I'm wrong, which is most of medical school. In my own chart notes, I chart what is relevant to the patient. So it's often, this is a 26-year-old patient who's presenting for gender affirming hysterectomy, whatever. You know, if I want to get more specific into the anatomy that that person has, and we can do that at a different part in the note or in the exchange, but I try not to use the binary, the medical binary, in the way that I was trained, which takes a lot of undoing, even for a trans person like myself. You can advance. So this, okay, I just had to do a plug here because this drives me wild. I am a OBGYN, and it is, so every day I'm subjected to the idea of gender surprise. So, okay, we all know gender reveal parties, they burn down half the country this summer, right? They are very real, and people have this. It's you know, now we can do non-invasive prenatal testing, which can look the reason that the sex chromosomes were involved in that is you can have differences of sex chromosomes, right? So differences of sexual development. So you might have one X chromosome, you might have three X chromosomes, you might have two X's and a Y. This was information, medical information, that was designed to have to kind of understand, okay, what might be associated with a patient who has one X chromosome? What are the things that we're going to look for that to keep that patient safe? What it's turned into is, ooh, I get to know the gender of my baby when they're just barely graduated from an embryo to a fetus, right? So they barely have their own little placental situation, and we're already gendering them. Gender is always a surprise. It's a surprise for me every day of my life. I'm like, oh, what's happening today with my gender? I don't know. We'll find out. So I am really aggressive with my chart notes. Whenever I see this, or people will ask, what are you having? What are you having? And it actually took me a while. So I have kids, and it took me a while through my partner carried the pregnancy, and there were two of their other twins. And people, even as an OBGYN, people be like, what are you having? I'm like, I don't know twins? I don't know what you mean. What do you mean, what am I having? Anyway, so I just wanted to take this, get on my little soapbox. This is an OBGYN. Okay, go ahead, Jackson. Sorry. Okay, so few common terms. This is, as you all know, so we have languages evolving rapidly and every day. And I work mainly with cis straight people in my life, and because of COVID and those twins that I mentioned, I don't get out very much, so I don't hear a whole lot of language as it evolves. But basically the words that I tend to use, I like to use the word transmasculine or transfeminine, because for me it just sort of is a gesture in a direction along a spectrum that's very fluid. So it tells me a little bit about where someone might be falling on a spectrum, but it doesn't nail them down to one identity at any moment. Of course, if someone tells me I identify as a trans man, I identify as a trans woman, I identify as a cis woman, you know, whatever, as a non-binary person, we'll use those terms. But in general, when I'm communicating about stuff like I am right now, I'll say transmasculine, transfeminine, just to kind of to implicate sides of a very fluid spectrum. Yeah, so a lot of the terms that I use with my community, and that some people, again, so when people see that I'm a trans person and they come in to my office, sometimes they're very surprised. My bio is available on KP, the National KP website. They misgender me there, but I'm working on that. I've been working on that for 2 years. But a lot of people don't know. They come in and they thought, oh, I thought you were going to be a 70-year-old man because of my name. That's often the demographic is like older, senior cis men who have this name. But anyway, so when people see me as a queer person or as a trans person, oftentimes, there'll be code switching that will happen. You'll use terms with me that they may not use with my very lovely but cis straight colleagues, and so when I talk to people, I get give lectures to wide audiences. I get a lot of people asking, is that an offensive term to use? Often it's about the word queer. It was kind of the initial word that sparked this anxiety for people, and I mean, yeah, it could be. So it kind of depends where you fall in the landscapes of identities, what your dynamic is with that particular person. I think that there's no calculus that you're going to be able to be like, okay, hang on, BRB, I'm going to plug this into my app and it's going to tell me whether or not this term is appropriate to use right now. You just have to use your judgment. And if you are a cis, straight, white person, there are going to be terms that are always off the table for you, and you just kind of have to be able to reflect patient language when appropriate, but also rein yourself in and realize, okay, is this term something that is for me to use? And again, I don't have a badge buddy or anything that I can give you, but just kind of be thoughtful about how your own identity, your own space that you take up and your own privilege and kind of how that will interact with your patient language. You can go ahead and advance. A couple terms that I want to bring up, just in terms when we think about trauma and we think about accessing gender-affirming care. I started working at Outside in 2005 at it was called the Trans Identity Resource Center. It's now an administrative building. But I remember we had this chunky desktop computer, and on that we had a file that was called Resources PDX, and it was just a Word document. And it was basically a list of all different providers, so psychiatrists, social workers, primary care doctors, naturopaths, chiropractic docs, that it's not that they had any formal training to provide gender-affirming care, but they had been vetted by the community as basically not being transphobic. So, and that's how gender-affirming care kind of started, at least in Portland, from my experience, is that we were kind of scraping together bits of information that we gathered as a community. And we knew what words to say. If you wanted a histo, if we coded it as pelvic pain, right? That's something that we could do in terms of insurance, depending on which type of insurance you had, get it covered or not. But there is this dynamic with people who need gender-affirming care, who are often trying to find gender-affirming care from people who are cis, often cis and straight, that they need to rely on that cis straight person to believe in their identity and to believe in their experience of their identity and sign off on their identity in order to get care. So the idea of gatekeeping, that there's this power differential, it's incredibly real, and I would say even as trans care has become more, there's been more attention to it, there's been more standardization, this gatekeeping has almost gotten worse. And you advance. Go ahead, Jackson. So the real life test, so this was something, so speaking of standardization and that being actually having good sides and bad sides, the problematic part of it is, so there's something called WPATH, the World Professional Association for Transgender Health, puts up these guidelines, and there's a lot of discussion about who's sitting at the table to produce those guidelines. Are they reflective of the community that the guidelines will then be enforced on? I won't get into that today. That's a whole separate discussion. But anyway, so recently, like 2011, that was not that long ago, people were required to do a real life test before, real life test being like, okay, great, you identify as a woman, you have to live as a woman before we will support you with any medical or hormonal anything, right? So first of all, what does that mean, live as a woman? Like, obviously this is relying on the most basic, incorrect understanding of gender identity, gender performance, gender constructs, right? Like, but it's also, for some people, very dangerous. For a lot of people, very dangerous, right? So you say, okay, you need to come out, you need to perform the gender that we expect of you without any support. So this is asking people to lose jobs, lose family, experience violence and murder, obviously, are huge threats today, ongoing to people with trans experience. So the medical industrial complex does not have a good history of supporting trans patients or gender diverse patients. And so when we're contextualizing all of these different things, I think understanding that legacy of trauma and of abuse of power and how it continues to this day and has kind of shifted shapes a little bit, but is still present in pretty much any conversation you see, that I see, when particularly cis doctors are talking about taking care of trans people. So we can go ahead and advance, Jackson. So we were talking about that. Okay, so this is upsetting. Okay, yeah, one time I gave a lecture, it was maybe 3 years ago at an academic institution. And afterwards, I had someone come up, and I knew him. He was a cis, straight, white man, doctor person. And he was like, oh, great, okay, so great talk. So, but what do we do for all of our residents who have to deal with trans patients who are just angry? They're just angry for no reason. Like, what? And then we have to deal with this angry trans person, and like, we didn't do anything. So who's helping us deal with that? And I was like, okay, all right. Unpacking that level of entitlement would take more than the like 45 seconds I had to talk to this person, but it made me inspired to mention anytime I talk that trans people are never angry for no reason, and Black people are never angry for no reason. People of color, poor people living in poverty, people experiencing houselessness, people, as you're mentioning, Jackson, who have experienced genocide, people who are oppressed, on a very systematic level, institutionalized, are never angry for no reason. And so to understand kind of the community trauma that, depending on the many different identities that any one person can inhabit, how does that on a daily basis, what do they go through? What does their life look like? What opportunities have they been given or not given based on their identity and the legacy of all these different systems of oppression? How does that affect how they are in your clinic that day, or how they are when they show up for their surgery? Being compassionate, understanding that if you see a patient who's in your clinic and maybe this patient is in a bad mood, realizing that it's not about you as a provider to be like, oh, someone take care of me, I'm dealing with an angry patient. It's about understanding why is that patient upset? What can I do from my point of privilege to support this patient? Maybe consider how did this patient get here? Where's this patient going home to? What happened when they were on the bus? What are they worried about when they're leaving here? All these different things. So anyway, contextualizing community trauma when you're interacting with the individual patient, I think is critical. You can go ahead and advance, Jackson. So I think we all know what homophobia is. And we'll kind of go over this quickly. I think, so we know what homophobia is, we know what transphobia is. You know, I think that when things are overt, when you see overt homophobia, overt transphobia, overt racism, things that are easily identifiable as an ad hominem kind of attack on someone based on an identity that someone is interpreting, that's, most of us can kind of get that, right? I'd say there are other more subtle ways of undermining identities. Heterosexism is a huge thing that happens. It happens, and it's interesting too. You know, one of my colleagues that I trained, we went to medical school together. We trained at OHSU together. We're both trans. She and I were talking once, and she's like, "It's amazing when you're in this context where you just are working with cis straight doctors day in and day out, you start to forget that there are other identities. You're like so used to being the only queer person in the room that you forget that there might be another queer person that you're just overlooking, because you're starting to buy into this heterosexist idea that heterosexism and that everyone baseline is heterosexual, baseline is cisgender, and then everyone else is kind of an anomaly." You can advance, Jackson. So this is an example of me in clinic where I'm the patient, which is actually not true, because how I present, people are usually like, it's more kind of curiosity. Like, I have no idea how to contextualize you. I don't know if you're a trans person. I don't know if you are, which way are you going? Like, so this doesn't happen to me a lot, but this would happen to my partner, who, you know, is a femme cis queer woman. You know, do you have your boyfriend? What does your boyfriend do? What are you using for birth control? Oh, who's in the room? This must be your sister. You guys look so much alike. Yeah, you can go ahead, and that's just me in the next slide. They're looking mad. And you can keep going. So yeah, so it's it's hard, right? But when you're in any clinical interaction, it's not as hard for people who are like, everything in my life is gay. Every thought I have is queer on some level. So it's not as hard for me. But like I was saying, even you put me into medical training where I am kind of hidden from queer people for 8 years. It's easy even for me to be like, oh, right, I forget that I'm not the only queer person in the world. So anyway, microaggression, this is also something that people are becoming more aware of, and that makes me, I'm very happy to see this. I've seen trainings on understanding how these can affect people over time and affect work environments. And microaggression, so this term was coined in 1970 by Dr. Pierce. And I want to be very specific that it was initially outlined to describe the dismissals that he witnessed in African American identified people in the 70s, which he defined as a casual degradation of any socially marginalized group. So these constant they're often kind of dressed up as compliments, you know, things like, oh, your English is so good. Like, yeah, I'm from Baltimore, you know, all these different, or like with trans people, oh, I would never have guessed that you were ever a woman. Okay, I wasn't, right? So these, and they build up over time. So there's a lot of information about microaggressions. You can get really deep into it, but just understanding, so you can understand overt transphobia, homophobia, racism, all these things, and then you can kind of contextualize, okay, how does heterosexism play into that? How does all of that then mix with the microaggressions that someone's experiencing as they check into my clinic, as they are being roomed by my medical assistant, something that maybe the resident said to them before I see them. All of these things add up to create and awfully exacerbate people's experience of either personal trauma or community trauma. You can advance. Okay, so, and how much, Jackson, I have how much time? 44. Okay. Okay, good. Just stop me if I need to stop talking. Okay, so this is amazing. When I was at UCSF in San Francisco, there were these badges, these badge holders, and only queer people wore them. And so it was great because as a little haggard queer medical student at the VA, I'd be like, did I just see a rainbow button in the cafeteria? I did. It's like these kind of beacons of you're not alone. And then I came to interview for residency, and I interviewed at OHSU and interviewed at UW, and everybody had these buttons, and I was like, oh my God, I don't know what I was doing in San Francisco. Like, everyone up here is gay. And then I realized that I was at a dinner for one of these places, and this resident had this badge on, and I went up to her and I was like, oh, hey, what's it like being a queer person in this program? Do you feel like they're supportive? Do you feel like you have community? And she was like, oh, I'm not. I'm like, I'm straight. I was like, okay, right? Like, wow. So not only was that a tool of a sort of false allyship, but I would much rather her be her weird, like, vaguely homophobic self at the dinner alone without luring me in with her little rainbow badge buddy. So I feel like it was like a little like, oh, hey, come talk to me, and then I can be homophobic at you. So that was new. I was like, oh, great. People are just like, oh yeah, I want a rainbow badge buddy, and they sign up for it, but there's no work required to actually wear that. And so it's just creates this false sense of safety. So what can you do other than just get a badge buddy? So first of all, I was joking, but also not joking when I was at OHSU that I wanted to design a training and then a quiz that people had to take. And if they didn't pass it, I was going to take away their badge buddy because they didn't deserve it. But I didn't, whatever, maybe, in my free time, I'll do that. But what can you do? Educate yourself. So don't make, and this goes the same for white people, right? Like, as a white person, it is my job to combat my own racism and the racism around me every single day of my life. It is my job to do my own homework. I do not call my, Black and Indigenous and people of color friends to be like, oh, hey, is this racist? Am I being racist? No, that's my work. It's the same thing. Queer and trans people, you don't ask queer and trans people to do it for you. You don't call your trans friend up and be like, oh my gosh, pronouns are just so hard. Will you explain them to me one more time? You can do it. You actually have to do it, or I'm taking your badge buddy away. You can advance, Jackson. Okay, so there's lots. So the internet is amazing. The internet is fantastic. There are still books, actually, turns out, like books that you can open up and read that have pages on the inside, which is great. But there's also, I would say, social media has made this very, very easy for people. So when you just look at your feed, right? So then, and again, when I think about my own work that I have to do, I make sure I'm not on social media very much, but I have Instagram, and I make sure I am following the people that I need to be listening to, right? So following the leaders of Black Lives Matter, making sure that I'm following leaders in Indigenous movements. Then there's other kind of spin-offs of things, like I did a program recently called The Nudge, which was designed to kind of help people make steps towards dismantling racism in their everyday life. That's all through social media. And so it's really easy. You can do it. You can go ahead and advance, yeah. So about clinic is hard. Clinic is oftentimes we're not in control Especially as a medical student, you have zero control. You don't even have a place to put your bag usually. As a resident, you think you have control, but you actually have none. And then as an attending, you still don't have control, but people think you do. So but it's important, I would say, and we've done this a little bit at Kaiser when I got there, because we have Kaiser's this thing. It's a building. You walk in, and then there's like peds clinic, there's rheumatology, there's dermatology, and there are all these different doors. And so the waiting rooms are right outside. And so our OBGYN waiting room is very much like I am sitting in an OBGYN waiting room, which for some people can make people uncomfortable, kind of depending on how they identify with that and their own gender identity. So, things that I did was with reaching out to patients and saying, hey, we are right next to rheumatology, and if you would prefer to sit on the rheumatology side of a waiting room, my medical assistant will kind of call out to the general room for anyone to come back, so, and we can go back through the middle kind of door that you don't know if you're there for OBGYN or rheumatology. Other things, so signs, visibility. This has been a big thing recently with Black Lives Matter, making sure that there are clear messages when you walk into a space about where people fall with that. Bathrooms that are not gender specific, hugely important. Kaiser actually does a pretty good job of that. And again, you can't put all this up and then not train anybody. You can't be like, oh, it's a safe zone, I'm an ally, and then have your front desk people misprinting people all day long. So you have to train those people who are meeting patients from the door. And a lot of people, they want to do a good job. I think that they want to be affirming, but they don't know how. And as a queer person who grew up, I was like a baby gay and a baby gender expansive creature from the moment I hatched or whatever. It's hard for me to forget that this isn't easy for everybody. So you need to give people the tools that they have to succeed. For example, I had a patient who woke up from surgery and overall had a good experience, but sent me a message and was like, oh, hey, just FYI, my recovery nurse said these things. And so I was like, thank you for telling me. And then I gave a presentation specifically to that group of nurses who are dealing with patients as they're waking up from anesthesia, often from gender-affirming surgeries if they're my patients, and being like, hey, look, I know that this came from a spot of wanting to be like, I want to know more about you. I want to understand your experience, but it comes off as very alienating. And so why don't you ask people about, do they like to garden, or what are they watching on TV, versus like, when did you first know that you were trans? Okay, we can keep going. Okay, so I also, as a gynecologist, it's interesting when you're trained. So I was trained a certain way, and then I realized that when I could do what I wanted to do and what felt appropriate to me as a human, as a queer person, as a trans person, they were really different things. And so now that I don't have someone watching me, I can do whatever I want that makes sense to me in a patient interaction. So basically, when you're training in gynecology, or actually as a med student in general, you're told to ask very, very specific questions that are super, super personal. So I have a different way to go about that. But I think, again, to kind of reiterate, how do you actually create a space where a patient's going to feel more comfortable disclosing stuff to you? You can't pretend. You can't pretend that you're an ally. You have to do the work that then whatever that community is that you're trying to show up to as an ally will identify you as an ally. I don't get to identify myself as an ally. The communities that I want to be an ally to, they get to tell me whether or not I'm being an ally, and they will make that designation based on how much work I've done. So you have to dismantle those things to create a space that's reasonable. You can't fake it. And then think about what you really need to know in that patient interaction. So they teach you in med school, ask like the most graphic and specific questions about what people do with their bodies and other people's bodies. And I don't feel like I need to do that in order to assess people's risk, either for a surgical complication or for, something that can be transmitted with sexual contact, whatever. So do I need to know people's name and pronoun? Yes, always, 100%. I don't care. Yes, you need to know. I clarify everyone who's in the room. So there's less people in the room now because of COVID, but we still do have people, so poor people come to procedures or surgeries or whatever. I ask my patient's name and their pronoun, and I ask the people who are with them, what is your name and what is your pronoun? Don't just ask pronouns if you think someone is you're like, oh, you might be trans, maybe I should ask. Just ask, because you don't know looking at somebody. Do you need to know their history of accessing gender affirming care or their history of experiencing a trans identity? Maybe. You maybe do, you maybe don't. So that's when when questions were being asked of my patients that were not from needing to provide medical care, but were coming from a place of I'm curious about this. If someone is coming in because they have a cellulitis, on their arm, it doesn't matter. And I mean, unless, it does not matter what their experience has been accessing gender affirming care, if they have or they haven't, or they plan to in the future. That's not what they're coming to you for. And the same thing with sexuality. So for a lot of my patients, and again, this is just what I do because it seems to work well for me. A lot of my patients I'll do gender affirming HIS for, and I used to, when I was training, and I hear surgeons have conversations with patients about that before I was attending, I'd hear people asking kind of questions about what kind of sex they have, what types of things go in. I had one provider would say the space formerly known as a vagina, which was like a funny joke, but not actually, because it for a lot of people is still known as a vagina. Ask them what it's known as. Anyway, but I usually will say, just when I'm talking about pelvic rest after a procedure, I will say, for anyone who puts anything in this area of the pelvis for any reason, I say don't put anything there for 12 weeks. I don't care what it is or why you're putting it there. Just don't put it there for 12 weeks. Now I don't need to know what your sexual practices are ever, unless you want to tell me as your gynecologist. I just need you to have the information that you need to keep you safe. You can advance, Jackson. And history of trauma, so that's similar, right? So I always, especially as a gynecologist, come into any clinical interaction assuming that there is a really good possibility that the person that I'm interacting with has either experienced trauma from sexual misconduct, or has experienced trauma on a community level, or has experienced trauma from a medical provider or in a medical setting. And so I don't ask. We do have intake forms that have kind of a checkbox that ask about a history of experiencing different types of sexual assault, sexual trauma, sexual misconduct. And when patients, and we'll get into that a little bit later, but so that's an opportunity for patients to disclose if they want to. But generally, I don't ask explicitly any questions. I just create a space where they feel like they could tell me once they get to know me if they feel like it's relevant to their care. You can go ahead and advance, Jackson. Okay, so in terms of, so I'll talk more about kind of what that looks like, but in terms of asking pronouns, I always have people being like, well, what about cis straight people? Aren't you worried that they're gonna be confused if you ask them what their pronoun is? I'm like, excuse me? Are you asking me if I'm worried that I'm gonna offend a cis straight person? No, I'm not. If they don't know what a pronoun is, great, that's a perfect time to explain what a pronoun is. Awesome, little education moment for everybody. So usually just with my patients, I'll be like, hey, what do you go by? What are your pronouns? Awesome. I'm Jean, I use they, them. And that's it. But again, that's easy for me because I'm a trans person. We can skip the pronoun stuff, Jackson, because basically, we can do it. Anyone who wants to ask questions about that, you totally can. But it's just practice. And if you're not used to using pronouns, and you're like, oh, I'm so freaked out about using they, them as a singular pronoun because my allegiance to grammar is just so profound, then work it out with someone who's not trans. Practice with your cis friends. Just be like, oh, hey, we're going to practice. Okay, intake forms. So this is where sometimes people will, first of all, look at the forms at your clinic. Be like, are these forms inclusive? Are they capturing information that I feel like is appropriate? Are they going to alienate people? Start there. And then if it's a good form, this one's from Fenway in 2014, make sure you read it. Because oftentimes, and you can advance, Jackson. Oftentimes people will put something on the form that they won't that's easier to write down than it is for someone to say in a face-to-face interaction. So I'll always look through that, and that I would say that I do ask direct questions if someone has indicated on the form a positive screen for something, because for me that's an invitation to talk about it. But rather than asking specific questions about trauma, before I do any exam, I always ask patients, have pelvic exams ever been painful or difficult for you for any reason? And the response is, oftentimes people are like, they're uncomfortable, but I don't feel like more than is normal. Some people might elicit that they have a history of vulvodynia, a painful condition of the vulva where it is horrifically painful to even have a speculum placed at the introitus. And other people say, yeah, emotionally it's really hard for me. And in which case, if they say yes, I'll say, is there anything that you've ever done that you've ever tried or has ever been done to make it easier for you? And if they say yes, then okay, great, that's easy. So then we'll try to do that. If they say no, then I will say, okay, kind of figuring out where the patient's at in that moment. I always will say, well, how do you feel about being here? We have in my clinic, we have lollipops, like little organic suckers that people can have for painful procedures. We have heat packs, we have squeeze balls. And I'm like, if you want to listen to your phone, you can listen to your phone out loud. You can put in earphones. You can listen to me if you want to. You don't have to listen to me. I'll tell you everything I'm going to do, but you can put your earphones in. And if I need to get your attention, I can get your attention. And then I also make sure that people know that if walking into the clinic does not commit them to an exam or a procedure that day. I've had patients who we just practice. So I'll be like, hey, you're here. That's awesome. I am so happy you're here. And that doesn't commit you. You are not committing to anything by walking in the door. You are 100% in charge. And if you want to be done and you're like, all I could do today was come in and talk to you, then that's completely up to them. And I also make sure that they know that if something like a procedure, actually even an exam at all, if they need medication, so like an anxiolytic prior to the appointment, that they can come back with that. If they need somebody to be there with them and they didn't know that was an option, that they can do that. Or some patients, I'm like, hey, if you need to go to the operating room and you need to have anesthesia to get this done, we can do that too. So I make sure that if they're feeling unsure about their ability to complete whatever it is, exam or procedure that day, that they know what their options are and that they don't feel backed into a corner, that this is something that they just have to get through. With the exam, so this is interesting too, and kind of when gender-affirming care and trauma-informed care come together, is that you'll often hear usually cis people kind of talking about how trans people we're uncomfortable with our bodies and going to be offended if you call something a vagina, or you are a pelvic exam is just going to be horrible for us or whatever. So there's this this is kind of, I mean, overcompensation, I don't know what it is, but this assumption that because we are trans, we are therefore inherently uncomfortable with our anatomy or have some level of trauma there. We all have various levels of trauma for various levels of for various reasons. So don't ever assume, for some trans patients, they're like, whatever, no problem. I've had 3 babies. I don't care. I'm totally comfortable with anything GYN or obstetrics or whatever. And for other patients, that's not the case. And also for cis patients, that could not be the case for other reasons. So just don't make any assumptions. And then I also ask patients, and this is particularly true before I do an exam, but also when I do surgeries, before I describe the surgery, I ask, are there any terms that you want me to use or to avoid when I'm talking about your anatomy and how it relates to the surgery? Because when I talk, especially with surgery, I want to be very specific about where incisions are and how things heal and what to expect. But I want people to still feel as if they're in control about what words I use. Or if they're like, well, I don't have any words I specifically want you to use, I always ask, make sure there's any words they want me to avoid, because sometimes that's more important to people. And then with the exam, I check in a lot. I don't know, maybe it's too much, maybe it's annoying. I do tell patients you can just ignore me, but I do at every kind of point, I ask, how are you doing? Are you okay? Is anything painful? And that's with everybody. So, because oftentimes, especially with the doctor-patient dynamic, people won't tell you, like, oh yeah, I'm being pinched, that's actually, that hurts, or I'm having a hard time, or this has gotten difficult. So I always open that door constantly throughout the exam. We'll talk about other things. Some patients don't want to talk about other things, but regardless of whether or not we're chatting or not, I always take, before I move on to anything, before I, open the speculum to find a cervix, before I lock the speculum down in place, before I use a scopette to visualize, to remove cervical mucus or whatever, I am always asking permission to move forward with the next part of the exam. And I'm always making sure that whoever it is I'm taking care of is doing okay in that moment. You can advance there, Jackson. So overall tips, obviously, like I said, it's nuanced, and every patient's different. So I think in general, use gender neutral language as much as you can, and period. I'm trying to teach my 2-year-olds that, right? Like, they'll be like, man. I'm like, that's a person. Where'd you get the idea that, how you know? But you're 2. And I do the same thing in clinic, right? I patients, person, support person. You don't need to use gendered language. Don't assume people are straight. Don't assume people are monogamous. Don't assume, and this is important, I think, because this happens actually a fair amount, because as a gynecologist, we're always thinking about pregnancy risk and kind of family planning control for patients. And when I hear my colleagues ask, about someone, they'll find out that someone has a boyfriend. I'm like, that means nothing to me in terms of assessing, is this person at risk for pregnancy or not. Like, when I want to know if someone is at risk of pregnancy, I ask specifically, do you have any sexual contact with someone that produces sperm that you are concerned could lead to a pregnancy, or do you have any questions about that, right? Because some people may not know. My partner is a trans woman who has been on hormones for this amount of time. We don't know. What's happened? Does she have sperm? Does she not? All these things. So I would just create a context to learn more, to actually get to the points that I need to get to take care of the patient, not just because I'm like, oh, you have a boyfriend. Oh, you must be at risk for pregnancy. That doesn't mean anything. And with that, I ask very open-ended questions. And if I do have to ask an invasive question, like I would say when assessing pregnancy risk, my questions are more invasive than they generally are. I'll usually preface it with something like, do you have any concern, or do you have any questions about your level of risk of pregnancy? And then we can, or if someone asks, if someone responds that they have a boyfriend, then I'll ask, does your boyfriend have a penis or not? And for straight patients, they're often like, what? And whatever, so then I'll clarify that I'm trying to figure out is there introduction of sperm into your body? That's all I'm trying to ascertain. And then I only ask questions that are relevant, right? I don't ask any questions where I'm like, I'm just kind of curious, who do you date? No, not only if it's going to change what we're talking about in that particular moment in that clinical interaction. So I think that's it. There's lots of, you can advance and see if there's, whatever. Practice. And, good point. Myself. I did that. If someone discloses to you, so I will, when I ask a patient what their name and pronouns are, and they tell me, and it's not reflected in the chart, I will always ask them, is it okay if I put that in your chart? A Kaiser comes up with pronoun and name. And if they are telling someone for the first time, I don't want to just jump ahead and put it in their chart, because then their dermatologist is going to see that, the orthopedic surgeon is going to see that. So I just always can, and it's the same thing. If someone discloses a history of trauma, I ask, is it okay if I put this in the note? And because other people can read it. So, meaning other people take care of them, obviously. But anyway, okay, I think that's really it. That's all I have. There's some resources here if you need them.
Sorry, figure out how to unmute myself.
Are there any questions, Jackson, that you know of in a chat, or no? It doesn't look like it.
Yeah. I'm going to go ahead and ask you a few questions.
Yeah.
Are there any specific resources here at the end that you wanted us to call out?
My favorite one is transhealth.ucsf.edu. Maybe because I trained at UCSF, but they have a website that is updated constantly, and it has amazing resources for clinical protocols, but also general just gender affirming care overall. Kind of how do you interact in the world in a way that's gender affirming, from like name and pronouns to aftercare after vaginoplasty. Like it's the whole gamut of getting more and more specific. Fenway also has a lot of really nice online trainings out of Boston that I've really enjoyed. Those are kind of the two that I would recommend the most. I go to the transhealth.ucsf.edu website a lot, and its stuff is always changing on there.
Cool. Yeah. One thing I wanted to mention, we do have, at OHSU, we have actually a small group of transgender identifying students who are leading and guiding our nursing school on creating curriculum to educate providers and specifically in the nursing school on working with trans and gender diverse populations. And I know we've just been really excited to hear about that sort of leadership at OHSU and support in terms of students and employees who also identify as trans. And I guess I'm just curious because I do know we have managers and directors watching. I'm curious if there's anything that comes to mind of efforts that folks have made with you in the past, and any examples that you want to give where you felt really supported in your work, or you've seen other individuals of other identities also supported. Any examples like that folks could hold on to would be great.
That's a great question, Jackson. I think, and it's interesting too when you look at the hierarchy of medical training, because that puts a whole different spin on my experience. I think that as and also that I was in San Francisco and then I was here in Portland. I mean, I would say that it was, and as a resident particularly, so as a med student, you know, I ran a transhealth elective down in San Francisco and had a lot of support to kind of do whatever I wanted with that. And then, but it wasn't until my last year that we actually had a faculty kind of take over to provide formal leadership or guidance with that, you know. So I think that, and I think that that was 2010 to 2014. Was it? Oh my God, it was. Yeah. So, so I think it then, but so there's kind of, my experiences were informed by being a medical student and a resident and attending, but also it being 2010 to 2014, 2014 to 2018, and then graduating in 2018. So there's been this multiple factors that have affected it, but I'd say like probably the most notable one as a resident, and I guess I'm just gonna be frank, that when you're a resident, you have an attending who is kind of the ultimate authority on everything, even if you're a trans person and have been working in gender affirming care for, 10 years at that point, and you're attending as a cis person who maybe is brand new to this and actually doesn't know anything about the community. It was very hard to have people kind of listen. I mean, I'd say that my program certainly listened. My residency program did a really good job at listening. I mean, they had, my class of 7 people. We had 2 people come out in different ways in my class. So I had top surgery in my second year. So I had to take time off. And it really, and I was like, I'm having top surgery, and so it kind of created a moment where they're like, okay, let's like check in about your identity. And when I arrived at 2014 as an intern, when you're an intern in a surgical program, it's like, you just want to cover your head and just not be noticed and just survive. Right. And so I basically said to them, I'd been out as a non-binary person, as a genderqueer person forever. And then when I got there, I was like, just yes, I'm a non-binary trans person, but you use she, just use she, her with me on the words, right? Like, just do that. But that, because I thought that would be easiest for them, but it wasn't actually. So people were still having a really hard time with that. And so finally, when I had top surgery, I was like, okay, well, now that didn't work, and it seems like I'm getting more confidence in my role as a doctor, and feeling less like I need to hide and survive my training, and more like I can be a little bit more vocal. So I came out with my pronouns, and my program did an amazing job of adapting to that. And then my colleague came out as trans, which I don't think anybody expected necessarily. I mean, she and I are very close, so that's different. But from an administrative level, they were like, "Whoa, what? Okay," and so they adapted really well. But I would say my ability to actually make an impact on the care of trans patients was largely stifled by my role in the medical hierarchy as a resident, as a physician in training, But when I came to Kaiser, they have been amazing they actually defer to me nearly completely. I got there and I was like, look, I hate that we're requiring letters for this surgery that we don't require letters for cis people. We need to change that. And they're like, okay, so let's start working on that. Whenever there's questions about gender affirming care or what to do with a particular patient case, they come to me, which it feels so wonderful that people are actually understanding that that's important, that someone's that overlap of identity of a patient and provider is hugely powerful, and I think that for the first time in my career, I'm at a place where that's actually celebrated. So I'm super, super happy to be able to do that. And more of my patients are trans or gender expansive or queer or whatever. I just feel like finally they have access to me. Because as a resident, actually, I wanted to put in my bio like that I was a trans person and interested in taking care of trans patients, and they were like, no, we can't do that because all the residents need to have exposure to trans patients. But there was no curriculum to actually make that safe for trans patients. So so from there to being like, basically anyone can see me who wants to see me, feels fantastic.
Thanks for sharing that. I really appreciate you sharing that, and just especially when not everyone in our communities is open about their story, and so I just want to acknowledge that and appreciate that you opened up and shared that with everyone watching, and really appreciate that. I think also one of the things that really stood out to me was your comment about residency programs being all encompassing. I think a lot of folks can definitely identify with that, and I think that it's interesting to me to hear you talk about back then and how fast our programs and our institutions have worked to get to the point of where they are for patient care, and then now seeing a lot more support for students and employees or changes trying to be made in that direction. And one of the things that you also commented on that made me think that comes up, especially because, like you said, residency programs are all encompassing. It's not uncommon for providers they get to the point where they're working with patients who are exploring their identities, and suddenly they're exploring their own. And just as a social worker, we talk a lot about transference and ensuring that we really make sure that we're making space to take care of ourselves when we go down that road. And so I guess just in terms of the story you just told, and then working with providers today, if you have any thoughts around resources for providers who may need to step back and or step aside and explore their identity more, or identities more, especially as it relates to gender, I think that that's something that that definitely can come up for folks, when they get out and they start working with trans individuals. And it's really, really important that, we keep tabs on that transference. So if you have any comments around that as well, and we have I want to say exactly 7 minutes left. So yeah.
Yeah, that's a great point, Jackson. I think it's interesting because as I mentioned, I came out. I mean, my coming out story there was never really any big reveal, in the sense that my gender presentation never changed from the point that I was a small child. So it was obviously, my parents, I had very supportive parents. So I wasn't forced into any type of role that I wasn't performing anything that I didn't want to perform. So I don't experience that with my patients in that regard, but I certainly, obviously, I have a job where I interact with people with a lot of different identities going through a lot of different things. And so that happens in other levels, in other ways for me. And so I think for me, in those moments, finding my allies that are in their colleagues. So, and reaching out to them to say, hey, I need to process this, or I'm finding myself feeling some kind of way about this interaction, and I don't know why I feel that way, or, why, or having feelings or judgments that come up about patients or about myself, or my abilities, or my worthiness to be providing care to patients, or any of these things that kind of will surface. I have identified, I did it at OHSU, I did it at UCSF, I've done it at Kaiser. identify the people that you can trust who know the specifics of the work that you do. So it's, like my friends who are social workers who work in academics or, work at Unity or whatever, they are experiencing similar things, but I don't know the specifics of their job. So for them, I would recommend finding someone in their network who they know exactly what that dynamic is, so that they can help you figure out how to either work through it with them if they're willing, or to help you figure out, like, oh, hey, we have this, like, we have a physician, I don't remember the whole acronym, but it's basically a physician support thing at KP for people who have had a difficult outcome, or, we all will. So knowing how to direct people, I would rely on my colleagues for that.
Thanks. My volume's a little loud, so we get feedback when I talk. I apologize. But yeah, I was just curious about that as it relates. That makes a lot of sense, hearing that, like, folks on your team that you're familiar with that you could connect with and get that additional support. And just in hearing what you're saying, the reason that came up for me is I know that I'm not alone in this, and that Stacy also, just in advocacy, we have heard from a lot of LGBTQ students in medicine who aren't always seen in their identities as being members of the LGBTQ community. And so it's interesting to hear you talk about efforts that were made once you and your colleague came out. And now I'm hoping we're making those efforts already. That's kind of, I guess, what I'm trying to say. And the only other thing I guess we could end on, because we have like a minute, if you have any thoughts around Trans Day of Remembrance is coming up at the end of November, and thoughts on resiliency or anything that you want to share, and anything you do to take care of yourself. And I think that's where we'll end. Really appreciate it.
Yeah, oh, that's lovely. Yeah, it's, I think I edited it out of this presentation, but oftentimes, because I have sat through so many lectures as a med student, when I was at Q Center, discussions talking about the poor trans patient, and it's often this kind of like cis savior thing where they're like, oh, we have to take care of this poor community because, they're suffering. And so I usually in my presentations start with, I love my community. I am so happy to be trans. I am so proud of my community, and I would not want it any other way. I've loved every, certainly there's things that we experience that make it difficult, and I come from a huge amount of privilege, and so I recognize that when I say these things. But my community is beautiful and has been there for me through everything. And I think that the process of medical training is a toxic one. And initially when I was a med student, I was like, let's get all the queer and trans people, into medicine, and really interested in pipeline programs that can help, students of color get into medical school. And then I burned out real quick because I was like, I don't want people to have to experience this. It's like so hard to be trying to be a medical student and then a surgical resident and being, experiencing all these microaggressions, or being constantly mispronounced, or dealing with people's, gnarliness on a daily basis. But then whenever I get to take care of a trans patient, or whenever, I get to spend time with my community outside of work, or whenever my community and my patients overlap, it's like, the most beautiful thing. Or I'll see someone, I'm like, were you a patient? Did I know you in the early 2000s? Because I don't know, but it's awesome. And I'm so happy to see you. And it's this familiarity that brings me back to, okay, so we're working hard to make medicine a less toxic place. And I'm so proud of my community every day. And I just love being a queer person. And I love being a trans person. And we don't need anybody to take care of us. Like, we've got this. It's just, we just have to, kind of be systematic and work together to kind of to improve our outcomes and our experiences. But I have no doubt that we're going to do it.
Thank you. I really appreciate it. Oh, we really appreciate your time. Thank you again for joining
Yes.
us. If anybody needs anything from us, please just reach out, CAP support at ohsu.edu, and we're happy to follow up with Jean if you have any questions that we can't feel like we can step in and answer ourselves. So thank you so much.
All right. Thanks, everybody. Take care.